Hi, my name is Diana Berrent. I am the founder of Survivor Corps, and welcome to the Survivor Corps webinar series. Because we know that you can't always get to the experts, we're here to bring the experts to you. And today we have an amazing guest. We have Dr. Vin Gupta, who I'm sure you have all seen on television, heard on the radio since the beginning of this pandemic. Our very own nation's Dr. McDreamy is with us. And because his list of credentials is so long, I'm going to let him do a quick introduction of himself, and then we're going to go right into questions because we have a lot for this one.
Diana, thank you so much for the invitation, and it's great to be here with the entire Survivor Corps community and all other viewers here for this what I hope is a really informative webinar. I'll keep my intro short since I know I held us up on the start here, but I am a pulmonary critical care doc with various roles in public health, one of which is I'm an ICU doc for the Air Force Reserves down at Lewis McChord. I've been caring for patients that are COVID critically ill since the beginning of this pandemic, and play a role at IHME, the Institute for Health Metrics at the University of Washington, where we've been doing a lot of the epi modeling and data analytics around what to expect. And so happy to talk about how to keep you and your family safe, especially in this holiday season. Then also certainly would love to talk about where are we headed as a country from a forecasting standpoint and what to expect. And so really look forward to this conversation, Diana, and thank you again.
Thank you so much. And thank you so much for your service to our country, both in the medical field, but also anyone who serves in our military is an absolute hero. So thank you so much. So I'm gonna do this so we start off and just sort of go through the viral timeline, starting with prevention and moving all the way through to long-term COVID, because you've seen it all. And so you have a unique experience and perspective where I think you can really walk us through the whole timeline. And so let's start at prevention because, obviously a lot of people in Survivor Corps have already had COVID, but we are just as concerned about reinfection. We'll get to that later. But we don't know what we don't know. So you are talking to people who are probably the most careful people in America about COVID, despite the fact that most of us have antibodies, not all of us. Because if you have been touched by this virus, there is nothing, you wouldn't wish it on your worst enemy. So keeping that in mind, there are still practical decisions that we are all wrestling with every single day. And obviously Thanksgiving is this week. The CDC just put out guidance on not traveling. And then I read a piece this morning in the New York Times in the editorial section about, all of the risks of being in a pod. And the author decided at the end of the day that he was going to travel for Thanksgiving regardless and see his immunocompromised family. Can you give your thoughts, and you can go into it a bit, on how to be safe during this holiday season? We're being told what we can't do. It looks like a long, dark winter ahead. What are safe activities? We go about this.
Diane, I'm glad you started with this topic because it's hard to do it justice in most other mediums like TV or radio. So thank you for the opportunity. This is what I would say. Without a shadow of a doubt here, we've been hedging on this question in public health for months now. Is it okay to travel safely in a plane? How can you travel safely on a plane? Is that even possible? Previously, so let me give some context here. Previously, there was actually a notion that maybe a plane is actually safer from a ventilation standpoint than an indoor classroom, where many of our nation's children are actually currently at right now as we speak, as we're having this webinar. And I think there's some truth to that, because we know that there's a lot of ventilation and air exchanges essentially every 8 minutes on the 737. There's been some great investigative reporting by Blaine and Alexander and others at NBC that have really double clicked on this specific issue. Ventilation is excellent on our airplanes. And so some of that initial data back in the summertime, actually, not in the bathrooms. The bathrooms is, for whatever reason, they just don't, they exclude the ventilation there. But what I will say is that in the summertime, there was a notion here that planes actually, with middle seat open with face shields and even a 3-ply surgical mask, that maybe you could travel safely. And that was sort of the emerging consensus. I'm not saying that there was full consensus, but there was a notion, well, is air travel actually that bad, especially if it's a limited duration flight? What we saw now is that actually in October, there was a study out of Europe suggesting that even with the best infection control measures in place, everything I just mentioned, that an outbreak occurred on a flight. I think it was between London and Ireland, that of 52 people on a flight, one incident case caused 13 other cases, and it was across the cabin. So I think individuals maybe seated somewhere in the back of economy, and folks up in the front of the cabin were infected. So it was alarming and evocative of what we've seen with bus travel and other forms of public transportation, especially studies out of China. So what am I getting at? I'm getting at that I don't think we really know. Some studies say, oh, air travel is actually safe. Others suggest, no, wait, it's actually the source of a mini outbreak. So that's when yesterday, for example, when Brian Williams asked me on air, what would you recommend to the 20% of Americans who are going to travel, regardless of what the CDC or what I say they should do, which is don't travel. You should not travel, avoid short-term goals like seeing family and loved ones. We all get it. We all want to do the same thing. Avoid it because there's going to be many holidays to come, and you don't want to risk anything in the short term or in the long term because of short-term gain. But Diane, I mean, here's the reality. The reality here is that not everybody's going to listen to what CDC says, especially now. And I would add that CDC issued guidelines within a week of people actually traveling potentially for the holidays. It's a little late. And their credibility something has been injured enough that it's really not going to change until the new administration takes office. And so what do we do? How do we talk to the 20% of Americans that are still going to travel? That's where my head's at, because I think a lot of people have changed their plans. It's not too late to change your plans. If you have a flight booked, if you're listening in on this webinar, it's not too late to change it, and you're still not going to lose your money. You can just rebook. Most airlines have pretty flexible travel change policies right now. If you're not willing to change your plans and you're still going to hop on a public form of public transportation, this is what I would suggest. This to me is what we just don't talk enough about. But I'll say this, Diana, I probably know about 15 couples, all in the medical field to some degree, who are traveling in some form of transportation, often personal automobiles, but a few getting on flights. If they have access to it because they were on an ICU shift recently, they're actually wearing an N95, right? They're wearing an N95, and then they're wearing eye shields. I won't demonstrate it again, but they're wearing face shields, eye shields, and they're wearing the best quality mask that they have access to. And they're testing themselves. They're quarantining now, and then they're testing themselves before they get on their chosen form of transportation. And then once they arrive wherever they're going, they're masking in the presence of their loved ones for at least 72 hours and then testing again. None of it is perfect. It's their effort to mitigate risk, but they recognize a wading into uncertainty. They're trying to mitigate it. I think that's better mitigation than what I'm hearing most other people are doing, which is hopping on a mask and crossing their fingers, not testing pre or post. The point here is that there's nothing you can do to fully eliminate risk with travel in the middle of an escalating pandemic. But docs and other clinical practitioners I know that are traveling are wearing an N95, and I think that says a lot. That if you have access to it, you're going to wear it for the reassurance of trying to mitigate exposure to loved ones on the back end or exposure to yourself. So if that's what people who know this virus really well are doing when they're traveling, what message does that send to the rest of us? That should send, I would hope the message to the rest of us is like, whoa, I don't actually have access to that. I should stay put. And even if I have access to that, it's not a smart idea to travel. But that's hard. That's a hard concept for all of us to wrap our head around. It's a hard concept for me to wrap my head around, frankly. I can't imagine how difficult it is for somebody who hasn't experienced this virus, who just wants to see loved ones. It's a hard concept to embrace and to really want to believe in.
So for people who are thinking, let's say people are thinking that they can test themselves into a Thanksgiving situation, into a car trouble situation. A friend of mine, her dad took an antigen test. It came out negative. Did the PCR test, got in the trailer, drove across the country 30 minutes prior to our arrival. The PCR test came back positive. How with, can you go into a little bit about the testing? There's been a lot of confusion about the new tests.
Yep.
And I know that there are different kinds. Can you talk a little bit about that?
Absolutely. Let me start by saying, and I actually have, I like demos as a visual learner. I have access. One of my roles here is to help vet rapid point of care testing. And this is, I'm not trying to endorse any products here, but this is to prove a point that this is a unique product. It's an endpoint PCR rapid test. It doesn't exist at scale anywhere. This is really just limited to healthcare settings right now. This is different from rapid antigen testing that a lot of us are hearing a lot about, because those types of tests are flooding the market. But high quality rapid tests just are lacking for a variety of reasons. I'm happy to talk about them. But Diana, to answer your question, the tests that exist right now in the market, the rapid tests, unfortunately, if they're negative, you can't necessarily trust that you're not infected, because the big con with a rapid antigen test is they have a high false negative rate. And we're recognizing this, that over the course of time, and this is not our first rodeo with rapid antigen tests. For the last decade, the way we test people for flu, every flu season, is a rapid antigen test. I mean, these rapid antigen tests have existed on the market for a long time for influenza. And in 2018,
is it the same thing as taking a rapid strep test, where you take the rapid strep test for your kid, and then of course you send off for the long version, and you wait until the long version, and the short version you only take it as a positive, it's a positive, and a negative you wait for the long test?
So strep is based on similar technology as the rapid flu test. Absolutely. So a lot of these types of tests already exist on the market. We just never talked about them as a rapid antigen test because it's confusing. Why would we reference antigen? It's just a rapid test for flu, for strep. The big problem here for both of these types of tests before, in a pre-COVID world, is societies like the Infectious Disease Society of America in 2018 actually said, we need to move away from rapid antigen tests because their false negative rate is as high as 30%. And it's causing a lot of people just to get false results. So we need to move towards rapid molecular tests. So these sort of mobile PCR tests, which just don't exist at scale right now, unfortunately. They will in a few years, just not right now. So that's the big issue here, is that rapid antigen tests have a high false negative rate. So to your point, Diana, if your friend tests themselves with a rapid antigen test before departure, and they say they haven't quarantined for a week prior, well, let's say they have and they've gotten a negative test, doesn't really matter. You can't totally trust that a negative is a negative. That's why that PCR test, which is hard to get now in Seattle, for example, actually all the drive-through appointments for PCR tests through a drive-through are full through the end of Thanksgiving, through the end of the Thanksgiving holiday. People just cannot get in for a PCR test in a drive-through anymore, which is why now in Seattle, they actually had to modify guidelines back to where we were in March, which is only come if you're symptomatic. It's pretty extraordinary right now that we still you cannot get a test in the city of Seattle. You can't book a test right now unless you're an inpatient. You cannot book an appointment for a drive-through test right now unless you're symptomatic. So testing is constrained. So it just goes to show, so one quick point here, that rapid antigen tests have a high false negative rate, number one. And number two, if you've been exposed to COVID-19, it takes at least 3 days, we think, before an infection might actually, 3 days of incubation before an infection might actually take root in your body. So testing within 72 hours of a close contact, actually, we think is, the false negative rate is super high. It's almost useless to test in those first 72 hours, but then up to 8 days after that exposure, serial testing in that window, that first week, multiple tests between day 3 and day 8, for example, we think is going to give you the highest yield to figure out if you're truly infected after that exposure. So timing of tests and the type of test are both important.
And obviously, the test is only captures that precise moment in time, because if you are online at that drive-through testing site and you go to get
Right.
tested and you've been online for so long, you go to use the public restroom, you know, which are horrible, pick up COVID right there, you're going to test negative, but you will be positive in 3 days, right?
It's true. It's true. So timing, 100%. So I mean, you're driving home the point perfectly, which is to say that a test at one point in time does not necessarily mean a negative at one point in time, even if it's a PCR test, doesn't mean that you might not test positive a few days later, especially if you've had a close contact, or especially if you've started to develop symptoms. Maybe you didn't know you had a close contact, or maybe you just picked it up naturally. Who knows? It's why getting a one spot test is often not sufficient, but access to multiple tests in a certain period of time is really vital.
So for those of us who have had COVID, the CDC has told us that for 3 months, they believe you have a certain degree of immunity, and you can't contract COVID during that 3-month period and pass on others. But what if we're re-exposed after the 3-month mark? I had COVID 9 months ago. You know, and it's especially important to understand right now as college kids are coming home. A lot of whom who had COVID in school. What are the guidelines if my entire family had COVID 9 months ago? If we are exposed, do we need to quarantine and test right now? At what point do we become just like everyone else? I asked Dr. Fauci, and he disregarded the 3 months that the CDC said, and just said everybody should, you know, consider themselves a de novo and, you know, get tested and quarantine as if they were anyone else. What are your thoughts?
I couldn't agree more with Dr. Fauci. There was a lot of pushback and a lot of angst when the CDC put out that information about 3 months of immunity if you've been previously infected with COVID-19, as though that was some sort of generalizable, like hard scientific truth that applies to everybody. That was false. There is definitely no consensus on how long immunity lasts if you've been naturally infected with COVID-19. I can cite multiple examples of reinfection where reinfection has actually occurred within a much shorter period of time. We have a notable case in Nevada of an individual reinfected 6 weeks after their initial bout with the virus. Both strains were genotyped and they were deemed to be different. And actually that second episode resulted in more severe symptoms than the first. We've long thought that if you've been infected once, that any sort of reinfection down the road that might occur will result in less severe symptoms. That is not proven to be the case, at least in this one example out of Nevada. But it begs the question, Diana, what do we actually know? And what is certainty, what's not? And the reality here is that we have had multiple conflicting data points out of multiple studies about how long natural immunity lasts and how effective that immunity lasts. You could have antibodies present with a qualitative test that just says, yes, you have antibodies, no, you don't. But it doesn't necessarily mean you have a titer of antibodies in your bloodstream that can protect against reinfection. Remember, we get hepatitis titers to see, do we actually have a protective level of antibody to COVID-19? We don't really test at scale titers for COVID-19 amongst those that have previously been infected with the virus. I'm not saying it doesn't happen. It's just not a protocol that's widely adopted. So the CDC sort of jumping the gun here and saying, hey, you're good for 3 months. You don't need to worry about getting retested was irresponsible. And that's why they actually walked back those comments. I will say, and so it's been removed from their website, and appropriately so. There was a lot of criticism for it. What you'll see, though, is that you'll see Senator Rand Paul and others sort of regurgitate that recommendation, and I thought he did so in a really concerning way, last week or about 10 days ago on national TV. And I think that, and he was wrong to do that, because there is no evidence that reinfection connotes immunity for a prescribed period of time for everybody. There just isn't. So come the holidays, especially if children coming home, I absolutely, your children, regardless of how old they are, I would really recommend at least a 72-hour modified quarantine. However you and your family want to interpret that, at the very minimum, everybody should be, or your children that are coming to visit, ideally should stay masked for at least 72 hours, ideally longer. I recognize Thanksgiving is essentially a 5-day holiday. People come in on Wednesday, leave on Sunday. I've heard some cases of students that actually, like University of Maryland, if you're going home for the holidays for Thanksgiving, you're staying through Christmas, which makes sense to me. If you're going to go and leave for Thanksgiving, and if you're a college student, you shouldn't be coming back until the winter holidays are over. That makes sense, because you really want people to do an appropriate quarantine, ideally test. But yes, I think everybody needs to act like no one's protected naturally from this virus. There's just too much uncertainty.
I thank you so much. I think that is extraordinarily informative and really, really helpful information for everyone who has college students. There have been huge outbreaks, as everyone knows, on college campuses. And I believe that there is a false sense of security among college students that they now have this get out of jail free card in their experience of having had COVID. So please tell your kids, tell your neighbors' kids, everybody, act like you haven't had it. I just came up with this, this question came up in real life yesterday before I go on to the next question. If you are hanging out with people outside, if you have a bunch of teenagers who are, walking down Main Street after school, do they still they were in school all day, they took mask breaks, they're not masked during lunch, they're walking down the street after school, it's cold out, do they still need to be masked all the time outdoors?
I get this question. I actually have gotten a variation on this question from parents who have children participating in high school sports, that their children are actually hanging out, and we don't really know what's happening, but they're hanging out in somebody's basement. They're not masked, and then yet we're putting all these stringent requirements on them congregating for practice. So there's this gap between what's pragmatic and what's idealistic and what's actually happening. It's hard for me to come on and say they shouldn't be masked. Ideally, you want to control what you can control, and what you can control is what you're seeing. And so I recognize that we can only advise and guide and control, and then ideally modify behavior that we're seeing and have knowledge of. If children are walking down a street distanced and they're outside, and you feel like that distance could be kept with some degree of, if they're truly 6 feet apart and they're outside, so I suppose in that idealistic world, maybe they can be a little lax on it. But I mean, realistically, are they actually going to be able to maintain that distance for the full duration of their walk outside? I think not. So my recommendation is always mask when you're in the presence of others, regardless if you're indoors or outdoors, unless you're eating or drinking. Maintain distance of at least 6 feet. Keep your mask on as much as you can, unless you're outdoor dining with a very small group of individuals. And that applies to teenagers walking down the street, and it applies to outdoor dining in places where that's happening with a very small group of individuals, something that I think we should be talking, maybe we can talk about outdoor dining as well. I don't know if that's helpful, Diana.
Yeah.
I think I've gotten myself into unexpected conversations with, say, the DC Athletics High School Association, where parents are really rooted on this question. I get it. Some people are saying, well, hey, doc, there's a lot going on behind the scenes, and yet we're doing all these rigorous sort of public health interventions when it comes to participation in sports. And participation in sports is really important for development. Why are we imposing all these restrictions? Because they're hanging out anyways. And it's that gulf between, again, what's idealistic and what's pragmatic. And and it's a tough question, but I think you guide on what you can control, and what you can control is what you're seeing.
It sounds like you had something to say about outside dining before I get to the next question.
Yeah, I know. I think on outdoor dining, this is where I try to. I know everybody probably has their own feelings on this, especially my colleagues in public health. It's I think it's important in hope. Let me start by saying the big issue here is that we haven't had public consensus and a uniformed approach for a lot of reasons, but one of which is that sometimes people just are going to do what they're going to do, or they're fed up and they're fatigued. And so I think part of what I've tried to do is say, if you're going to engage in public, or if you're going to do this and there's no way to talk you out of it, what can you do to minimize harm to others and then to yourself? Outdoor dining to me is in that sort of the Venn diagram of how can we do that safely while allowing you to go out and have a meal. And I think it's possible to do outdoor dining safely if you keep it to, CDC guidelines now suggest maybe less than 5 individuals. So what does that mean? Or so 5 or less? I don't know what that means in terms of a group. Is that just 5 friends, 6 feet apart on a table outdoors with some heaters around and everybody's masked when they're not eating or drinking? I guess that's what that means. Is that a couple meeting with another couple? Yeah, I suppose that's what that means. And what we do know on the data, let's go back to the data. The data suggests that the biggest drivers of transmission are clearly indoor dining, indoor bars, and gyms. Those are some of the largest drivers of transmission. Less actually when it comes to schools. We don't think schools, based on the data, again, it's not my opinion, are gigantic drivers of transmission of this virus, which is why you're seeing Governor Jay Inslee put in limitations here in Washington State on dining, bars, gyms, not necessarily cracking down on in-person instruction in schools.
We
Politically
did the exact
controversial, I get it.
City.
I heard.
We did the exact opposite.
It was interesting. It was interesting. I was wondering about that. I'd love to talk about that. But the data definitely suggests, and it's why you're seeing in Western Europe that our colleagues in Europe actually think that transmission, they don't buy into the notion that there's a lot of transmission happening in schools and that transmission is posing a risk to the greater community, which is why you're not seeing cracking down on in-person instruction in school as much as you're seeing it here stateside in certain states. But they have been very rigorous on indoor dining, bars, etc. And that's the approach we've taken here in Washington State. And I mean, frankly, I think that hews to the data and what we know, and that's not my opinion.
Yeah, no, I mean, with schools, my personal feeling is that we need to be having 2 different conversations about schools, one about elementary school children and one about high school and college students. I just be talking about pre-pubescent kids and post-pubescent kids and their ability to transmit, and just lumping them all in and creating one rule doesn't make a lot of sense to me. But that could be its own topic for, we'll never get anything. So my last question on prevention is, if someone is an asymptomatic carrier, I know there was just a new article published, I think yesterday, about saying that we're all pretty much contagious for the same period of time. Do you agree that 10 days is 10 days, regardless whether you are asymptomatic, whether you're symptomatic? We're getting a lot of data, but very few rules. I think people need some guidelines. What's your line if you are exposed? How long do you quarantine? And if you are positive, if you're asymptomatic and positive and symptomatic, what are the numbers?
Sure. So there's I'll give you my sense based on the data, and of course there's uncertainty with all of this. There's if you're asymptomatic, positive COVID-19. We think your infectiousness to others actually really goes almost all the way down to 0, not entirely, by about day 8. And so it seems like there's a huge inflection point in the curve of your risks to others by that point. So a little bit more than a week out post diagnosis. And so I think that's vital because that's why we're saying sort of that quarantining window of 10 to 14 days after a close contact exposure, maybe pushing that more towards 10 days, especially in a testing constrained environment where if you're asymptomatic, but you've had a close contact, at least here in Washington State and Seattle, you can't get a test. Knowing that you can maybe liberate yourself of a quarantine closer to a little past a week out to 10 days is better than 14 days. So that I think there is greater clarity. Of course, CDC hasn't updated their guidelines, and there's a lot of reasons why they're not good. I don't expect them to update their guidelines, but that's what the data suggests. In that sort of 8-day window, you're not as much of a harm to household members, for example, which I think is important, because I've heard from way too many people, Diana, about how like, hey doc, when can I come out of my bedroom? I'm losing my mind. And I've been getting sort of
18 days. I
What's
did
that?
18 days of
18 days.
18 days because I waited until I had a negative PCR test. It was back in March, and nobody had any idea how long you're contagious for.
Right, exactly. And so to your point, how long is the test going to stay positive versus how long you're a risk to others? Very different points, as you're noting. Tests can still stay positive, we think, for at least 21 days if you're asymptomatic but positive for COVID-19. It's why there's an evolving recommendation that if you've tested once positive for COVID-19, don't retest yourself for at least 30 days. Give yourself the ability to clear the virus. And that's why now there's more of that recommendation for a 30-day retest for whatever reason. If either you're curious, did you clear the virus, or say you have sniffles again and it's 30 days out, that's the right time to really get a retest. If you're symptomatic with COVID-19, I think that's the more open question. How long are you infectious to others? Turns out that the actual, at least the early data we have suggests that there isn't a huge difference in terms of infectiousness to others and risk to others between whether you're symptomatic or asymptomatic. And so by at least the data I've seen in the New England Journal, it still seems like 8 to 10 days, your infectiousness to others is greatly mitigated. I think the open question, my view, is what about the person who's in an ICU with severe COVID pneumonia or has multiple pre-existing conditions, requires hospitalization? Are we really sure that that individual has a higher viral load? Is that they're actually able to also clear the virus within 8 to 10 days? I think it's unlikely that those individuals, there's going to be the Bell distribution here, that most individuals will clear the virus between sort of that 8-day window, but there's going to be uncertainty around that duration. So some people it will take 14 days for them to really not be infectious to others. Others might do it sooner. If you're young and strapping and have a really robust immune system, maybe it's a few days, who knows? But I think 8 to 10 days is the prevailing wisdom or consensus that, I think that's when infectiousness to others really attenuates, whether you're symptomatic or asymptomatic. But the uncertainty is about those folks who get severe illness, have to go into the hospital. I think it's longer. I just don't know how much longer.
I mean, a lot of our members are continuing to test positive for months. They are told they are no longer contagious, but they are, I've objected to the term post-acute COVID because for many people, it remains acute or actually becomes more acute after the initial stage. And we don't really know that it's post anything yet. We now know that the virus can stay alive in the gut, in periodontal pockets, in various places in the body. And a lot of people who are dealing with long-term COVID are being denied going to the dentist months later because they are still symptomatic. And when you have to answer a questionnaire, you are still symptomatic, yet you had COVID. It's putting people in a very difficult situation where it's really hard to determine. Have you encountered this?
Yeah, I have. I've had situations where patients of mine tested positive 55 days out from their initial infection. Absolutely. And it's the nuance of, and I love kind of the way you phrase that we shouldn't be calling it post-acute COVID, because to your point, we're recognizing that however you want to term it, long COVID or whatever sort
Yeah,
of
I like long-term COVID. Long-term COVID.
long-term COVID. I'll start using that. Long-term COVID. Sometimes the symptoms can be worse than the initial presentation. To your point, Diana, and I think it's important for us to be really sensitive with language. This is what I've seen. I've seen that as we're learning more about long-term COVID and its impacts on the body, those symptoms, fatigue, shortness of breath, malaise, you name it, you can do it. I mean, all of you are better experts on this, frankly, than I am when it comes to living with some of these symptoms. It doesn't, I mean, that's an awful set of symptoms to live with, and there isn't scientific consensus on what does that look like, what's the natural history, what to expect, how can we best support all of you. We're also learning as we go. What does that mean in terms of, are you still infectious to others if you're testing positive with that symptom profile? This is where I think we can actually give some guidance to folks, because we're learning more that if you get a PCR test, in addition to whether it's a positive or a negative, there's a metric of viral load, the cycle threshold you'll hear a lot about, that Dr. Fauci talks a lot about, which is the higher that number and above, say, it's a number that ranges anywhere from, say, 10 to 40. The higher that number associated with a positive test, the less likely you are to be infectious to others. And the more that positive test actually represents residual genetic material of COVID in your body, but not live virus. Doesn't mean you're not experiencing the impacts of long-term COVID. It just means that you might not be a risk to others in terms of household exposures, you name it. So I think I would love to see anybody who has battled COVID-19 and is experiencing symptoms, especially, to be able to get that test and to be able to get that clarity, because there's evolving consensus that cycle threshold number that comes with a PCR test can be really useful to patients and to also departments of health who are trying to do contact tracing,
Right.
you name it.
Yeah, no, I'm fascinated by its use of measuring viral load of cities and neighborhoods as opposed to cases. But again, I feel like each of these questions could be its own webinar. Moving on to let's say you're diagnosed, okay? You've got COVID. You get the call from the Department of Health or your urgent care, wherever it is, you get a call, you have COVID. I have literally lost count of how many calls I've gotten this week from friends and friends of friends, all newly diagnosed with COVID. But we're in this highly unusual situation where we're telling people just to do the best they can until they literally think that they're dying, in which case they should go to the hospital. And there is no doctor in between. It's you go from diagnosis to hospital.
Yeah.
What advice, one of the frustrations I'm having with the system is that we have no standard of care for newly diagnosed patients. Hong Kong has the practice of giving everybody diagnosed with COVID a cocktail of an antiviral, an anticoagulant, and an interferon. We are told we are given Tylenol and Gatorade. What do you tell people who someone who's newly diagnosed with COVID that will keep them from getting into the hospital, that will keep the virus from progressing to the inflammatory and vascular damage that we're seeing in long-term COVID? What advice would you give somebody? What advice would you give your best friend who just found out they had COVID?
And Diana, so this is, I'll try to be concise here, but this is this is a complicated question. I think deserves a kind of a full treatment. Hong Kong's approach, and it's useful. I knew certain countries were really giving an upfront, early, aggressive treatment strategy, and I'm hoping that it's a randomized type of approach where some people are getting this cocktail, others might be getting a different sort of existing current standard of treatment. I'm hoping that they're doing studies around it, because as I understand it, and as my colleagues understand it, there is no consensus on what is actually effective early up front versus what's not. And the big concern, when you mention an antiviral, for example, remdesivir is kind of the antiviral that we've been talking about for months and months with COVID-19. WHO today just said that there is no evidence that remdesivir should be used in hospitalized COVID patients, and they are the ones that actually funded the largest trial, and they conducted it on this antiviral agent that has cost American taxpayers $100 million in R&D on top of the $3,200 our healthcare insurance will get billed if you actually do get prescribed this drug. So it's been a double charge to Americans in the absence of any data that it's actually truly effective. And so when I hear Hong Kong and other countries prescribing these cocktails, I think it's interesting. I just want to make sure that they're doing randomized trials to make sure that it's effective, because remdesivir and other agents you mentioned have a side effect profile that I want to make sure we're properly exposing people to, because we think that there's a benefit. This is what I would tell folks, and I get this question all the time from loved ones, from friends of friends, you name it. If somebody has a diagnosis of COVID-19, generally the call I get is, I'm feeling okay, I have the sniffles, I'm coughing, but I just got diagnosed with COVID-19. The only data that exists, and again, there's no CDC guideline on this, is, well, do you take vitamin D? And because some people suggest, there is some suggestion that a low vitamin D level is correlated with poorer outcomes from COVID-19 than if you have a high vitamin D level. Again, no consensus. I'm just putting it all out there. The other thing that so what I will recommend is, in the absence of a clear therapeutic that we can confidently prescribe upfront to the asymptomatic individual at home who's sort of wondering, Diana, to your point, what happens next? How can I stem badness from occurring? I guess what I would say is, we don't know what to do, because there isn't great data right now to suggest that early intervention with, say, dexamethasone, oral dexamethasone, might stave off progression into the hospital. And it's not because that wouldn't work, it just hasn't been studied. There's been a few times, I won't lie, there's been a few times where I've seen loved ones or friends of friends who have family members who are over 65 who've sort of been teetering 94, 95% on their oxygen levels. I'll always recommend anybody who has a positive test at home to get a pulse ox, measure their pulse ox every 4 hours, because we do think that if you have confirmed COVID, measuring your pulse ox at home and looking at trends every 4 hours might be helpful as an early signal that something's wrong before symptom presentation. That might actually be useful information, getting a pulse ox reading. You can get this from any department store. Where am I going with this? What I'm getting at here is, aside from vigilance, look at common, being vigilant on changes with shortness of breath, chest pain, cough, fever, and monitoring those every 4 hours to the extent possible while you're awake. The questions I usually then will wrestle with are, well, is there any indication here that prescribing oral dexamethasone might be helpful at home to stave off the inflammatory cascade as you just described, Diana? Intuitively, I would like to think that that makes sense, but then everything I've thought about this virus that I thought was true seems to have been disproven. For example, this inflammatory cascade that gets invoked by COVID-19. I was expecting that we would have seen a greater impact from therapeutics like this is technical language, or tocilizumab, or an anti-IL-6 agent that was studied with a lot of rigor over the last several months. This is one of the most potent anti-inflammatory drugs you can give anybody. And we were giving it like water early on in the pandemic, thinking that, it was the inflammatory part of COVID-19, especially in severe presentations, that was really harming people. Turns out that there's now no data, great data to continue to suggest its utilization in the ICU, so we've stopped doing it. I would think dexamethasone, it would make sense to me as a hypothesis that, dexamethasone, maybe there's a use case for it at home, especially maybe in those who might have a worse outcome from COVID-19 and are likely to progress, even if they're asymptomatic. Maybe we should give them dexamethasone at home and study it and see, are the individuals who get dexamethasone who are above 65, you name it, we can figure out the inclusion criteria. are those individuals who get dexamethasone at home as a preventative from going into the hospital, does it actually prevent hospitalization versus those who don't get it, meeting the same criteria? It just hasn't been studied. I'm not saying it doesn't exist, that benefit may not exist. We just don't know. But part of me, as we're talking about this is the question I ask myself all the time when somebody asks me for advice, and I want to give them something more than, hey, check your blood oxygen level. I want to give them something tangible. But the only things that have ever come to my mind in terms of tangible therapeutics are vitamin D, where there's some data, and oh, should you get yourself a stash of dexamethasone and take it at home? I've never actually encouraged it, but it's been a thought circulating in my mind. I don't know if that's helpful.
I'm looking forward to studies that look at the use of aspirin as a mild anticoagulant being given to people right at diagnosis. There's nothing cheaper. There's nothing more widely available. And now that we are seeing the extensive vascular damage from this disease, it seems like a no-brainer if your doctor allows you to take it.
Yes.
But that's something that Survivor Corps is working on, is to create we are working with scientists and doctors, and we would love to have you as part of this group where we are trying to come up with a standard of care for newly diagnosed patients so that we can keep people from ever getting into the hospital and keep them from suffering the long-term damage of COVID.
So I love that. By the way. I forgot to talk about aspirin, but no, the initial data on that as well. I think that's part of that toolkit, right? Is with steroids, aspirin, and vitamin D. Is that the upfront cocktail you give somebody at risk for bad outcome from COVID-19? Or an aspirin, I think that would be broadly applicable because, as you know, these vascular phenomenon happen regardless of age. And so, no, really interesting, and I agree with you. I'm looking forward to the studies.
So you mentioned the oxygen meter. I did not have access to that when I had COVID because it was too early on. We didn't know anything. At that point, it was early March. At what point, just going back so that people have some hard and fast rules, because all of this is so hard to keep track of. What point should you go to the hospital? At what point, like, when your oxygen, is it 90, or do you wait till it goes into the high 80s? What are the cold hard stats on the threshold of when you pull the trigger and go?
So this is coming from me, and I'll put my long doc hat on here. Not that wasn't on for the first part of this webinar here, but I think really relevant for the oxygen conversation. There is no hard and fast guideline for what's the threshold to call EMS or to say, I'm going to go talk to my primary care provider. But I will say that anything less than 94% merits a phone call and at least a discussion. And anything less than 90%, you should just go in and
is that lying down or standing up?
I would say in this case it shouldn't matter. But to your point, Diana, I think people have actually less. It's known that you take 20%. Your breath is 20% smaller when you're breathing kind of normally on your back than it is when you're upright. But it shouldn't necessarily affect your oxygen level unless you have kind of, in very rare cases, is kind of position going to affect oxygen levels. But so I'll focus on the majority of cases where position shouldn't necessarily affect your oxygen level. But what I would say is anything less than 94%, between 90 and 94, make a phone call. If you've been trending oxygen levels, as suggested earlier, every 4 hours, and you notice a decline from, say, 98 down to 94, that's also really useful information because that suggests something's evolving. Anything less than 90, again, these are not hard and fast thresholds. This is general mental models to kind of impart. Anything less than 90, is extremely abnormal outside of a select few cases. And even if you're somebody with, say, chronic lung disease, I'd want to make sure that you're okay. That's where I would make an appointment and or directly call EMS if it's in that range and you're also having symptoms. that's where you would be well within reason to just say, I need to go to the emergency room, or I need to go see my primary care provider, and just go. So I hope
think
that's
anyone's going
useful.
to the primary care provider with COVID. I don't think anyone is going to the primary care provider, which is sort of the problem, is that the first
Right.
line of defense for most people is the emergency room. And, that's, you don't want to do it unless you have to. But
And so that's where I would say, I mean, I guess just to be concrete, if it's, yeah, no, I mean, Diane, I hear your point here. I guess what I would say is, I know clinics there's been a lot of just structural barriers to access here. If you're less than 90, especially if you know you already have a confirmed diagnosis of COVID-19, definitely just go to the emergency room then if there's no other option. That's how I would think about oxygen level for sure. In terms of other concerning vital sign abnormalities, so high fevers, especially persistently above 104, checking it before you were to take something like Tylenol or Motrin, that would be worrisome to me, that something's going on here and you should get checked out. So persistently high fevers above 104, of course, low blood pressure. So anything, if you're not normally somebody let's say somebody is normally 120 over 80, a significant change from that, and I would say anything 20 points lower persistently is probably significant. I mean, again, I'm trying to give hard and fast numbers here when this is such a fluid situation, but that is also, to me, that would give me pause, and I would at least want to talk to somebody. If you're feeling syncopal or like you're going to faint, that's also concerning. And then shortness of breath, to me, would be the most telltale sign that something is deeply wrong. So if you don't have access to an oxygen monitor, but you're short of breath and it's escalating, especially if you're short of breath at rest, if you can't walk down a flight or up a flight of stairs at home, or if even walking on flat surfaces causes you to need to catch your breath, whereas previously that wasn't the case, or if you can't talk in full sentences, those are all concerning. And that should prompt EMS, in my personal opinion.
So I have about 9,000 other questions for you, and we have like 5 minutes left. So we're going to have to move to a lightning round here.
Okay, sounds good.
Because I know you have lives to save. So working off of your experience as a pulmonologist, I'm going to ask you all of the pulmonary questions we got all at once, and you can address them all together. So the question we received, sort of typical representations, were, have you seen COVID-19 survivors with lung nodules? If so, how can this be treated? Why do some COVID survivors experience rattling in the chest when breathing in and out, and what can be done to mitigate this? We're seeing a lot of people have developed ground glass granules in the lungs. Can this condition be treated or cured? Do you have any advice regarding long-term recovery post-COVID pneumonia? What would you suggest for COVID survivors with asthma? Basically, is the lung damage related to COVID reversible?
I want to believe it is, but I'm not going to sugarcoat the truth, which is I don't think anybody knows the answer to that. Ground glass nodules, opacities, you name it, generally speaking, resolve over time. And so if I was say your pulmonologist, what I would do is I would get repeat imaging, probably in this case, maybe a few months after your initial diagnosis. Typically speaking, after pneumonia, we get follow-up imaging 4 to 6 weeks after that initial episode to document clearance, to make sure nothing's wrong. And if there is persistent abnormality, sometimes we would even go with something called a bronchoscopy, a camera into the lungs, make sure we sample the fluid that might seem abnormal to make sure we're not missing anything, that we're not fooling ourselves that this was all COVID, whereas in reality, maybe something else is going on. So I would want to make sure that whomever your provider is, that there's vigilance. But yes, I do expect that ground glass in general represents inflammation and should resolve over time. But sometimes there's a lag between what you see on the image and what's truly happening in terms of symptom profile. There was a lot there, rattling in the chest.
I mean, yeah.
I guess I'll just quickly answer the rattling in the chest piece. That worries me that maybe somebody's developing bronchospasm, and could maybe an as-needed inhaler be helpful potentially, or just an incentive spirometer to help with deep breathing. I'm happy to also just talk to that individual. Diana, I was going to say, I can also just provide my email address so people can reach out directly if that's useful. So we can delve in
You will
deeper.
be bombarded. Say goodbye to that email address if once you put it out to 120,000 people who are desperate for medical care. But thank you. That's
No,
very kind of you. What other?
absolutely.
So that's another big question that we have is what kind of testing should we be getting after COVID? So much of this damage seems to pop up later on, and we're seeing frightening stories of people who are asymptomatic having heart attacks months later. My 12-year-old, just lost a tooth, an adult tooth, spontaneously last week, with no blood loss, not a drop of blood. The oral surgeons have never seen anything like it. He's being tested for whether they believe that's vascular damage, either in his tooth or the gum or the jaw. They're doing pathology and scans to try to figure it out.
Wow.
I was diagnosed with COVID onset glaucoma. They found microclots and fraying of the capillaries in my eyes. I sort of found it by accident. What kinds of tests should we be going for post-COVID for ourselves and for our children?
So I think anybody that especially is experiencing these long-term COVID symptoms, what I would recommend at a minimum, from at least a pulmonary standpoint, are pulmonary function tests. So if you're experiencing persistent shortness of breath, fatigue, persistent cough, I would at minimum want a pulmonary function test, and probably something called a 6-minute walk test. And then potentially, based on your prior chest imaging, if you've had any, a repeat either chest x-ray or CT scan to make sure that there's clearance, as we just talked about. To these other sort of vascular phenomenon, at the very minimum, there are lab tests you can get, like a D-dimer, and other studies of your coagulation system to understand, is there some sort of clotting abnormality that's happening that's causing these vascular problems? Are you at increased risk for that? So that's something to consider as well. And that's certainly something I would do if you were my patient. And then the last thing I would at least consider doing, I'm not saying I would necessarily reflexively do this, is an echocardiogram. So if people are having persistent shortness of breath, for example, can't just assume that this is pulmonary. You have to look holistically at the cardiopulmonary system and make sure, since especially we're still learning more about COVID-19, was the heart impacted? To your point, individuals are presenting with angina and potentially heart attack symptoms. Has the heart muscle been impacted? So I think a holistic approach, not being rooted, not feeling like you know the diagnosis a priori, keeping an open mind, are vital. But those are things I would be thinking about.
Well, I couldn't agree more with the interdisciplinary, non-siloed, whole body approach to this, because from a systemic issue, there's no better example that our body works in concert as a one uniform organ. We are not a bunch of body parts assembled together. I know that we are out of time and I have loads of more questions, but I'm going to leave it on one last question. Vaccines are coming eventually. We don't know exactly when, we don't know exactly which. And it seems like there will be different standards with different vaccines, and perhaps different vaccines will be more appropriate for different populations. And I don't want to get into the details because we don't know exactly what we're talking about yet. Until they're approved for the market, it doesn't pay to get into the details. We can have you back when they're out and we can discuss them further. But can you explain, do you have any sense of how this got so politicized? I mean, is there anything more, am I missing something? Is there something more political about this vaccine than the one for measles or for tetanus? And I heard you volunteer to go get the vaccine as soon as it's out. And I thought, I'm happy to go with you. Well, we could do it virtually. We could FaceTime through it. I mean, you're in Seattle, I'm in New York, but I feel like we could be first in line.
Sure.
Can you
Sure.
talk a little bit about, I don't get it.
I hate that we even have to have this conversation, but fundamentally, I think the answer to that question is it seemed as though there was political pressure to get the vaccine approved before our recent election. And as a result, people understandably were alarmed that a process that takes a decade at least was being accelerated to meet maybe goals that were not scientific. And so I will say that I think none of that has impacted this process. If anything, this is a credit to science and to the rigor and the fidelity and integrity of everybody involved. That we have, we have a solution that I think will end the pandemic by, I hope, end of Q2 2021, so we can all have some sort of awesome vacation in 2021 at some point. But I think, but I think convincing folks of that is it's going to be a lift. 1 in 2 Americans say they're not going to get the vaccine. So the challenge here is trust, communication, and trying to undo some of the damage that's been done. But I think it's been politicized because we were in an election year that really turned on the virus, and this was a clear flashpoint, unfortunately.
The numbers look extremely promising. I mean, there are very few new vaccines that come out with 94, 95 efficacy rate. I mean, it really seems to be astonishing. And the science is coming from, as far as I gather, uninfluenced bodies. You know, these are.
Yeah, they don't care. Nobody.
The same way that you trust antibiotics when you go, you know, to go back to our original strep comparison.
Right.
I hope that everyone out there listens to this, because this is an issue that is going to be front and center in the next several months. And it is an issue on which we need to act in as one American community. And the more people who take this vaccine, and until then act appropriately, mask, stay home, social distance, act appropriately. We are all in this together. There's nothing political about this virus. There's nothing political about the solutions to the virus. It is science, and we are one human community, and we all need to take care of ourselves, because it's not just your life at risk, it is everyone's life that is at risk. So please, please make the best choices and try to encourage everyone around you to do the same. Thank you so much, Dr. Gupta. I'm going to leave you to have your own final word to our community.
Well, no, Diana, I just wanted to say thank you. You've had a distinguished list of speakers, notably Dr. Fauci, not too long ago. So I took this. This was an honor to come and speak to all of you. What you're doing to raise awareness for long-term COVID. I mean, you're the national leader on this issue, and it's a big, under-recognized problem in my view. I don't think our healthcare system is ready to tackle it. I don't think the American people truly understand it. There's a lot unknown, but you're unpacking it in a really accessible way, and that's going to be desperately needed in loads in zip codes across the country, because people are asking these questions. They want help. So thank you for the service that you're imparting to all of us, for being such an incredible advocate, the entire organization. Thanks for having me.
Thank you so much. And since things are moving so quickly, we hope that we can have you on in another 6 weeks or so, and we can touch base again, because we'll be living in an entirely different world by then. You know, welcome to 2021. I can't wait to see you. Thank you, Dr. Gupta. Stay safe out there. Happy Thanksgiving. Stay home. Bye-bye.
You as well.